I now invite back to the stage our honored guest, Dr. Ed Oldfield, who will be presenting on the pathogenesis of Chiari 1 malformation and Syringomyelia.
Thank you. Good morning. Over the next few minutes, I'm going to limit my comments to 3 areas related to Chiari malformations and Syringomyelia. Those are going to be what mechanism might produce a Chiari malformation, the Syringomyelia associated with it. What's the pathogenesis of the Chiari malformation itself? Are the mechanisms underlying the development of a Chiari malformation and Syringomyelia the same? And how is the mechanism related to the goals of treatment? Why might we want to know these things? Well, one reason is simply aesthetic, and that is, as Dr. Osler said, to wrest from nature the secrets which have perplexed philosophers of all ages to track to their source the causes of disease. But we might also want to know these things for practical reasons, because the goals of our treatment depend on the disease mechanism. Understanding the mechanism might permit us to progress from empiric to logical treatment approaches, and it might permit us to select the most effective from among the least invasive treatments. There are many causes of Syringomyelia that occur at the level of the foramen magnum. Are we to suppose that there are individual pathophysiologies underlying the development of Syringomyelia with each of these entities? That doesn't seem logical. It seems more likely that one mechanism might explain them all. What is the best therapy? Well, clearly it should be related to the pathogenesis of the mechanism underlying the development of the Chiari malformation and the Syringomyelia. So by what mechanism does the Chiari 1 malformation produce Syringomyelia? There are several theories that have been proposed over the years. The 2 major ones were proposed, the first by Dr. James Gardner at the Cleveland Clinic, who proposed that the outlet of the 4th ventricle during embryonic development was blocked, and that permitted a communication between the obex and the central canal, permitting the pulsatile CSF flow during the cardiac cycle to go from the 4th ventricle down the central canal and expand the syrinx with each heartbeat. The other proposal, that of Bernard Williams from London, was that there was a unidirectional obstruction to the free flow of fluid in the subarachnoid space, so it was blocked going down but not coming up, creating a pressure differential during Valsalva maneuver, straining, etc., and pushing of the fluid from the 4th ventricle into the syrinx, once again through a patent central canal. But there are no studies documenting support for either of those theories. So in the early 1900s, we began to look at this at the NIH, and what we were doing was surgery in which we tried to keep the arachnoid intact because we were doing various physiological measurements. The cotinoid at the top that you see there is at the level of the foramen magnum. The arachnoid is intact. And we looked at the potential mechanism using several techniques. The most important one was intraoperative ultrasound. I'm going to show you a video of this patient in just a moment. As you can see, the syrinx extends up to the high cervical cord, lower brainstem in this patient, permitting us to monitor it during using intraoperative ultrasound. Keep in mind, now, if Gardner's theory is correct, we should see rapid expansion of the syrinx during the cardiac cycle, during systole. On the other hand, if Williams' theory is correct, we should see expansion of the syrinx during forced inspiration. Now, as we look at this, we're going to see the dura at the back edge of the spinal cord, and the syrinx. And as you can see right away, it's very pulsatile. But if we look more carefully, we see that as the tonsils are coming down, the upper pole of that syrinx is being compressed. So there's a systolic effect on the syrinx, compressing it from without at least on the superior margin. But if we open the dura, leaving the arachnoid intact, all that pulsatility disappears. And only now does the cord expand, the syrinx expand during forced inspiration. So these observations were inconsistent with Gardner's and Williams' notion. As part of that study, we also looked at the communication between the fourth ventricle and the syrinx using anatomic and cine MRI. There was no connection. But there was an obstruction to the free pulsatile flow of CSF at the level of the foramen magnum, as seen on anatomic and cine MRI. And there was systolic downward movement of the syrinx fluid during the cardiac cycle. Now, in the late 1960s and early 1970s, Georges de Boulay at the National Hospital for Nervous Diseases in London used ventriculography to study patients, some of whom proved to be normal. And he examined the movement of CSF during the cardiac cycle in those patients. And what he showed was that when, with a systolic bolus of fluid, delivering a large volume of fluid to the brain rapidly expanded. It compressed the third ventricle, and fluid very rapidly moved in and out of the cranial to the spinal subarachnoid space at the level of the foramen magnum. There's about 3/4 of an ml of fluid that moved across that space very rapidly with each heartbeat. So when our heart delivers a bolus of fluid to our brain, the brain rapidly expands. Our skull does not expand. So the venous system takes care of most of the capacitance of that, but not all. So there's very rapid movement of about 3/4 of an ml of CSF across the level of the foramen magnum with each cardiac cycle. If that's blocked, that fluid cannot move very rapidly across the subarachnoid space, and what accommodates that volumetric increase in the brain volume is that the tonsils, now impacted in the foramen magnum, rapidly move down and act on a partially entrapped spinal subarachnoid space, imposing an increased pulsatile pressure in the upper portion of the spinal canal. That was our theory. If that was correct, then any procedure that relieved that obstruction should provide effective treatment. So we had an hypothesis based on our initial study, and the main aspect of that was that the mechanism of Syringomyelia with the Chiari 1 malformation was on the outside, not the inside of the spinal cord. So John Heiss, at that stage, led a study at the NIH to look at the pathophysiology of Syringomyelia. Now, this was a fairly complex study requiring simultaneous measurement of various aspects of the physiology concurrently. John did a marvelous job of executing and successfully completing this study. We were interested in several aspects of examining whether downward movement of the tonsils on an entrapped spinal CSF space was associated with increased pulse pressure in the cervical spinal CSF. I'm going to go through some of these in more detail. You don't need to read them. In this design, we had 20 patients with Syringomyelia and Chiari malformation, and we compared them to studies of 18 normal volunteers. All pressure measurements were collected digitally every 30 milliseconds, and the pressure measurements, the cine MRI, the intraoperative ultrasound were linked in time using the EKG. With the obstruction to the CSF at the foramen magnum, we used anatomic MRI to examine it. And as you have seen in your patients, there was no space dorsal to the cerebellar tonsils at the level of the foramen magnum. Preoperatively, it returned to even greater than normal after the surgery. We used the Queckenstedt test before and 3 months after surgery, at surgery, while measuring ventricular and lumbar CSF pressures, and compared it to that of normal subjects. Now, keep in mind, when we do this test, what we're doing is the patient has a lumbar puncture, the jugular venous occlusion is performed in a standardized fashion, and we want to know how rapidly the pressure increases in the lumbar CSF. In the normal patients, as you see on your left there, there's a very rapid rise in the pressure in the lumbar area with venous compression. But it's a much more slow slope in patients with Chiari 1 malformation, as you see on your right. In the middle of the patient panel, you can see that if we do this Kreckenstedt test during surgery, and we measure the pressure from the ventricle, there's a very rapid rise, but that's delivered very slowly to the lumbar CSF pressure. It returns to normal after the surgery. That was so for our patients as a group. As you can see, the pressure was blocked preoperatively, but it returned to a normal state postoperatively and was comparable to the normal volunteers. We wanted to know if there was excess pressure and pulse pressure in these patients in the cervical and lumbar areas. I'm showing you the cervical pressure here. It was increased preoperatively. Absolute pressures and pulse pressures returned to normal after the surgery. Is the upper portion of the syrinx compressed by downward movement of the tonsils during systole? I'm going to show you a video in just a moment. In it, downward movement is red, and we're going to be looking at the intracranial pressure at the top on the left of that panel, and the cervical subarachnoid pressure as we go through a cardiac cycle. As you can see, there's pulsatile movement of the tonsils coming down, compressing the upper part of the syrinx. And if we march through one cardiac cycle, you can see that as the intracranial pressure and cervical pressure reaches its peak, the tonsils are down and the upper pole of the syrinx is compressed. We also examined the measurements during the cardiac cycles and showed that the syrinx diameter was minimal when the syrinx pressure and intracranial pressure were elevated. Was the cerebrospinal fluid partially entrapped? For this, we measured compliance. The way you do this, you just do a lumbar puncture, remove a volume of CSF, measure the pressures before and after, and measure the change in pressure per ml of CSF. And as you can see, it was compromised preoperatively, but returned to normal postoperatively. We used MRI, cine-MRI, to look at the flow of fluid during the cardiac cycle. And as you can see, during the black here, during systole, there was a rapid downward movement of the cyst fluid. There was no movement across the subarachnoid space at the level of the foramen magnum. So I think these studies have shown us that the pressure and the high pulse pressure is occurring in the cervical subarachnoid space, but we also wanted to know, is that responsible for fluid moving through the spinal cord and into the syrinx? And this is a study that John Heiss just finished a few days ago. It's not published yet. But as you see that column on your left, that's preoperative. We put water-soluble contrast in the lumbar area, and we're doing CT scans at the site of maximal dilation of the syrinx, at C6 in this patient, at intervals after the injection of the contrast. And as you can see, before surgery, the contrast very densely enters the syrinx, but does not do so after the surgery, indicating that the mechanism underlying the rapid movement of that contrast into the syrinx has been alleviated by the surgery, and indicating that the fluid's coming from the subarachnoid space through the cord into the syrinx. So all these measurements, all these observations were consistent with our hypothesis. But what we've shown is that increased pulse pressure reduced compliance in the subarachnoid space and the spine, and the other physiological observations. Some of those are present in patients with brain tumors who have high intracranial pressure, patients with hydrocephalus. The thing that's different about them, in contrast to the patients with Chiari malformations, is that there's a partial block of the subarachnoid space, and that's essential. For instance, we do have circumstances in which there's Syringomyelia without a Chiari malformation at the level of the foramen magnum that we know is caused just by a block, as in this report by Jerry Oakes and his colleagues with a Chiari 0 malformation. The same mechanism should permit us to explain the underlying development of a syrinx with all these different etiologies of Syringomyelia at the level of the foramen magnum and the spine. So what is the pathogenesis of the Chiari malformation itself? In this study, Dr. Bastorth and his colleagues showed that in many patients, but not all, with about half the patients in fact, there was a reduced volume of posterior fossa in relation to the tissue components within it. We also know that that occurs in some other species. These are King Charles Cavalier Spaniels. There was an off-breed of the King Charles Spaniel that was originally bred in the 1500s. And it was bred to have a certain shape to the back of its head. And that gradually reduced the size of the posterior fossa, leading these very cute puppies, dogs, to have a very high incidence of Chiari malformation and Syringomyelia. So the small size of the posterior fossa explains some of the patients who have Chiari malformations, but not all of them. We recently examined this at the University of Virginia in this study by one of our neurosurgical residents, Davis Taylor. I had observed several years ago that some patients with Chiari malformations have a lot of extra space, as you see on your right here, in the posterior fossa, but still have a Chiari malformation. Others, shown on your left, clearly have a small posterior fossa in relation to the space available to the tissue. And as you can see on the graph on the right there was a difference in the relationship between the tissue volume and the posterior fossa volume in these two subsets of patients. We also have circumstances. This is a Chiari malformation. Is it congenital? Well, probably not. It's just occurring because of the pressure imposed on the brain from above, pushing it downward. This has been reported also with patients with chronic subdural hematomas and other problems with the mass effect hydrocephalus, as in Chiari's original description. We also wanted to know, well, what happens to the cerebellar tonsils after you do surgery, and if you observe the shape of the cerebellar tonsils over time. So we studied 48 patients, another study led by John Heiss, 39 of whom had Syringomyelia. And as you can see in these two patients, there was disappearance of the Chiari 1 malformation after foramen magnum decompression. That also occurred in this patient and in this one. It happens every time. That malformation has disappeared if we get rid of the impaction of the cerebellar tonsils at the level of the foramen magnum. So the Chiari malformation, I don't know if most of you saw Michael Taylor's really brilliant talk yesterday, but what he told us was there's no such thing as a medulloblastoma. Well, there's really no such thing as a Chiari malformation. It's simply the product of impaction of the cerebellar tonsils in the foramen magnum over time. Our heart beats about 120,000 times a day, so it's easy to understand how that impaction might produce that abnormal shape that we see. It's acquired, not congenital. And that's why just about any operation that we do that frees up that space is effective. In this meta-analysis of treatment of Chiari malformation in children, it was shown that there is effectiveness if we do or do not open the dura. One of the advantages of opening the dura and doing a dural graft is that the need for reoperation is diminished, clinical improvement is increased, and the incidence of decreased size of the syrinx is increased compared to just bony decompression alone. But that comes at the expense of having higher complications, such as CSF-related complications and wound infections. But there's very little, in fact, there's no information, essentially, of whether just opening the partial thickness opening of the dura doing a bone decompression is effective in adults. In this study, Aaron Bond, also one of our residents at UVA, used intraoperative ultrasound to monitor what was happening across the subarachnoid space during surgery. And we were misled by it because with the patient's head inflection, it looked like we'd done enough surgery when the bone decompression had been completed, so we stopped. And in the adult patients, the ones that we just did a bony decompression, what we discovered was almost all of them came back later requiring another operation to open the dura. So it may not work. The reduced operation may not work in adults. So to summarize, the mechanism of Syringomyelia, its origin and progression, is on the outside, not the inside of the spinal cord. Effective treatment occurs when the obstruction to the free pulsatile movement of the cerebrospinal fluid at the foramen magnum is eliminated. Successful treatment occurs with any procedure that accomplishes that. The morphological abnormalities of the cerebellar tonsils and the dorsal subarachnoid space are as acquired by impaction of the cerebellar tonsils in the foramen magnum. The Chiari malformation should not be considered a malformation. It's simply an acquired abnormal shape of the cerebellar tonsils that occurs because of that impaction. Let me close by acknowledging the several people that were involved and who did the studies that I've shown you. John Heiss supervised many of these studies, but he had a lot of support in our studies. The original study by Corinne Marasco, several of the studies by our clinical research nurses, Hetty DeVroom and Renee Smith, our neuroradiologist, Nick Petronas, at UVA, Aaron Bond, Davis Taylor, John Jane Sr., and John Jane Jr. Thank you.